Today we're going to talk about stroke, how to assess it, how to identify it, and how to treat it. We are recording at this point in time, so glad that you guys are here. Stroke's a general term that we use that basically means any type or incident where we have an interruption of blood flow to the brain. Now, this interruption to a blood flow generally will come about because of one of two reasons. One is a blockage, or number two, an aneurysm. And they both present differently, and they both have different outcomes. As a result, there's a couple of things that we want to be aware of. Number one is regardless of the cause, we have an interruption or a disruption of oxygen that is being delivered to the brain tissue. Now, here's the other thing that you want to kind of keep in mind. If we have a patient that has a stroke who is also potentially having a diabetic emergency, we want to do our very best to identify the type of stroke that the patient is having. Because if you keep in mind, and we'll talk more about this in a minute, if we have a patient that has a hemorrhagic stroke and we introduce high concentration of glucose into the blood, now guess what happens? That comes into direct contact with the brain tissue itself. And as such, now we've made a bad situation worse. We'll talk a little bit more in just a little bit about the parameters at which we want to look at as far as glucose administration. Here's the other thing is these that you want to remember. You remember the rules that we have for oxygen administration for cardiac patients? Same rules apply to your stroke patients. Okay, because remember, a stroke is nothing more than same type of etiology as a patient who has a heart attack, except it's happening up in the brain instead of the heart. So we want to kind of keep that in mind as well. Now, at one point in time, I worked with a paramedic down in Georgia, smartest paramedic I ever known. The dude was always in trouble though, okay? But you couldn't help but like him. He was always in trouble. So they put him with me to try to keep him out of trouble. And basically what happened was he got us both in trouble. But he asked me one time why we ran emergency traffic out to stroke patients and then we ran non-emergency back in always with them. And I said, well, the reason going out was that you get your information from dispatch, you're not entirely sure what is going to be there. Sometimes patients will call a stroke, and it could be a heart attack, could be anaphylaxis, could be anything else. When you get there and the stroke has already happened, there's literally nothing that can be done for the patient, even if the stroke gets worse. So unless that they're in some type of life-threatening condition, there's really no reason to run back. Well, about 20 years ago, that began to change. And so now today, stroke patients, if it's recognized early enough, and if they are transported to definitive care, you can completely reverse the effects of a patient having an ischemic stroke. Nothing you can do about a patient having a hemorrhagic stroke. We'll talk more about that in just a minute. Your standard of care right now is to, number one, identify and to transport to the nearest appropriate facility. Think of your transport decision in the same way that you would if you had a trauma patient. If you've got a massive trauma patient, they're not going to your 4-bed ER in your community hospital. You're going to put them on a helicopter and you're going to fly them to a hospital in Lexington or Louisville or wherever your nearest stroke facility is. Well, a trauma center is. The same thing holds true for your stroke patients. Isn't that right, Sydney? Isn't that right, Sydney? Here I am trying to pull in some of your experience. Sydney got to see this with a stroke patient with PHI. Is that who you flew with? So tell us a little bit about that with the stroke patient that you were involved with.
So we got called out to transfer a guy from London to UK. He was hiking in the woods with his wife. We were hiking all the time. And then he's had some leg numbness that eventually made it to the right leg. And then, so she has to go to the hospital. we got there, they did the stroke assessment. I didn't really feel him for the stroke assessment, so I couldn't tell you about function. But when we got there, we're like, "What's your name?" So we said his name, and we're like, "What's your birth name?" And it's like spelling his name. And we're like, "Okay, well, who's this?" He's like, "That's my wife." And then we just kind of started like going downhill. Because he'd already been here for 2 hours. So,
Have they given him any TPA as far as the medication to dissolve the clot, which is what we're going to talk about next?
he did have CPA, and apparently his CT is
Okay.
really good CTA.
So I think you said he had slurred speech by the time you got him up. Would you take him to UK or Central Baptist?
He
UK.
was, his speech was kind of bad when we got there, but it wasn't like terrible. And then within the 30 minutes, it was back.
Okay. So Sydney got a really, really good experience. Now you can go back to ignoring me.
Oh,
Okay, carry
I
on.
had a chaotic
So-
experience with stroke.
So, well, I'll call on you for examples in just a minute. I want to make sure we get through the content. So that's the thing that you're looking for is getting your patient early identification. And part of your responsibility, we got to be better at this. Fire service has almost completely educated themselves out of business. Only 20% of calls for a fire department are to fires. The rest are EMS related. And one of the things that we need to do in EMS, whether it's fire-based, private, or third party, is that we need to do the same thing. So anytime you get a chance to educate somebody about signs and symptoms of stroke, do it. Because early recognition is the key for this to help things to begin to turn around. Now, one of the nice things about this, especially we were talking about with ischemic strokes, is that you can, well, you can't, but the physician can administer TPA. TPA stands for tissue plasminogen activator. I'm not going to ask you what it means, but I do want you to know that it's the same type of fibrolytic that's utilized in patients that have heart attacks when they inject to go in and dissolve a clot. Now, there are some limitations for TPA, in particular within the brain. The size of the clot matters. If the clot is too large, they may not be able to go in and dissolve the entire clot. Now, there are some things you got to be concerned about. In fact, that if the patient's blood pressure is really, really high, they might not be able to utilize that as well because now they're going to be concerned about an aneurysm. If you have an aneurysm and now we've got all of this basically a platelet inhibitor on steroids that's floating around there, now our patient is going to bleed out even more profusely. As we're looking at this, the big thing to remember is that patients that are going to get TPA, the sweet spot is about 3 to 4.5 hours. Now that can be bumped on out somewhat if you're dealing with, say, like a facility at UK, Baptist Richmond, that is literally a teaching hospital where they have neurologists and neurosurgeons, just a phone call away. In your smaller areas, like in London, typically you will have the ER doctor that will give the TPA in conjunction and after consultation with a neurologist to do that. Now, you and I won't be giving TPA because it's just too risky. And so the thing that we got to be able to identify with these patients is their last known normal. Last known normal. And we'll talk about that as well. Now, one of the nice things, especially when you're transporting your patient to larger facilities, is that they can bump that out, like I said, to about 6 hours, because what they're able to do is they're able to thread a catheter up into the brain, up to very, very close to where the clot is, and apply the TPA almost directly on the clot. That can be done in about 6 hours after that. Although better outcomes, like anything else, Ryan, better outcomes are associated with those shorter windows because we have less damage that has been involved and we have less cell death that has been involved with the patient. Now, again, one of the things that's important for you to do is to try your best to identify when the symptoms began. Second thing you need to do is that if you've got a person with you that has identified when those symptoms began, bring that person with you if at all possible. Because basically what happens now is you may not be available to answer any questions. You're going to drop the patient off Muna, and then you're going to go back in service. And the physician or the neurologist may have some questions that they would want to ask specifically about when these symptoms had their onset. Having that person there that was with the patient, Aziz, will be very, very valuable for that particular patient. There are some exclusions of when they're not able to use TPA. So if your patient has had any type of head trauma or a stroke within the last 3 months, okay, and it doesn't matter whether it is an ischemic stroke or a hemorrhagic stroke, that excludes them out. Going beyond that and let's just set it at 3 hours for right now, going beyond that 3-hour window in a smaller community or going beyond the 6-hour window in a teaching facility also will exclude a person out because the risks are too great as far as administering that medication. Now, sometimes they're actually able to go in and grab the clot and pull it out, or much just like you can with your heart, they can go in with a tiny vacuum cleaner. You think I'm joking? That's exactly what it is. It applies suction, and they go in and they grab the clot and they suction the clot out. Right.
How is using TPA on someone who's had a stroke in the past 3 months increase the risk?
When you have a stroke, you're weakening the vessel. And again, one of the associated things with strokes is that your blood pressure has a tendency to go up. So what they're really concerned about is that weakened area in the cerebral arterial system blowing out. And now you've got, number one, a hemorrhagic stroke, but we've got all of this TPA that's floating around and making the patient bleed even more. Okay, good question. So if we've got a patient with, in particular, any type of a subarachnoid hemorrhage. Now, why subarachnoid? Why do you think a subarachnoid type of hemorrhage would be a problem? More part of the arteries. You're exactly right. And again, those vessels are high pressure. Therefore, now we're going to run the risk of causing our patient to bleed even more. With a subarachnoid hemorrhage, even under normal circumstances, that part of the brain can fill, or the cavity can fill with blood really, really quickly, again, because it's coming from an artery. And so we can begin to see an increase in intracranial pressure coming on very quickly. Patients that have subarachnoid hemorrhages will often present with a sudden onset of a headache and a stiff neck, because the muscles now begin to spasm up. The other thing that comes along, just like we see often talking with patients that have head injuries, is nausea and vomiting, and in particular, projectile vomiting. Now remember, projectile vomiting is entirely different than the vomiting we get when we've had bad Taco Bell, okay? So bad Taco Bell is you just go and you vomit, it's all over, and you eventually feel better. With projectile vomiting, what you're seeing is that it is under force and you become like one of the fountains that you would see in Europe. I mean, it is just going. I can remember one time I had a patient in the back of my ambulance with a stroke, projectile vomiting, and his vomit hit the back door of the ambulance. It's really quite impressive.
World record for that is actually like 27 feet. Projectile vomit.
Yeah, right.
That's what I know that because I'm ready. I'm ready to watch out. 27
You know how this, how?
You don't know about your random facts?
I am not ready for that.
27 feet.
Yeah.
That's a 3-story building.
Pretty far.
Was that person possessed at the time as well?
I don't know. It's in the book of Mormon.
It sounded like something would come off of the old TV or the old movie, The Omen, or The Omen.
Gotta watch it.
Okay. 27 feet. Okay, now
Imagine that.
you're going to make me waste even more time now because I'm going to have to look that up, okay? If you've got a patient that's had an arterial puncture, so arterial puncture would generally be a patient that has had any type of a blood gas that has been occurred, or if they go in and they've had either some type of an angiogram, in particular to go in for a heart cath, because they will go up in through the artery because it gives you larger vessel, more direct access to the heart. Blood pressure of greater than 185 over 110. All right. Again, the big issue here is going to be worrying about that aneurysm blowing out. So yes, Sydney.
So like if somebody's mid-stroke and say they've had a stroke like months ago or any of these things, they're not gonna be able to tell you.
Not necessarily, okay? So now remember, you can still sometimes speak, sometimes your speech is slurred, okay? And sometimes your speech would be perfectly fine, but you would have paralysis on one side. So again, as we talk about in particular the Cincinnati Pre-Hospital Stroke Scale, it's one or more of those 3 things that come into play. But that would be something that obviously, if your patient has a family member or something, you can gather information from them. You're going to be limited if their primary display of the stroke is going to be an interruption of their speech, but it doesn't always happen. Bella.
You'd be worried about the vomiting and the stroke, because what if they bagel down and then you're dropping the pressure? The pressure is drops.
We'd actually want them to vagal down and drop their pressure if that were to happen. But again, when you vomit, you're causing the pressure in your head to go up, even though the heart rate may go down itself. But the other thing that we're going to be concerned about with them vomiting is what? Airway. Okay, especially if they begin to lose consciousness, or if they've got paralysis on one side. Now we already have a patient that cannot maintain their airway, because if they're paralyzed completely on one side, neck muscles are also going to be paralyzed. Okay, so that's the thing to keep in mind. Good questions. So as we're looking at this, yes? In that situation, Lyndon, yes. What we would do is, one of the good things about that is that depending upon their injuries, they're going to be going to a trauma center anyway. Let's say if their injuries are not that serious, I would still send them to the trauma center, because the trauma center, let's say that you've got an option. Let's say you're with the air medical crew and you're doing a scene pickup. So, and you've got the option of taking your patient either to UK or to Central Baptist or Baptist Lexington, both very good hospitals. Have no complaints with either one of them. In the scenario that you're giving me, if I were the medic in charge, I would go to UK, because now we're not entirely sure what's going on from a trauma perspective, but UK also has neural services as well to deal with both of them. Here's the thing to keep in mind. I'm giving you this information. This is not for you to eliminate a patient from going to a stroke center. You still need to send your patient to a stroke center, okay, or a stroke-capable hospital. It's to help you to know how severe your patient is actually presenting, okay? So, hypertension, let me back up here. BP of 185 systolic or 110 diastolic. This is one of these always. One of the few always that I want you to remember. Anytime that you have a patient and you get called for a nosebleed, it's not going to happen very often, but occasionally you'll get called for a patient that has a nosebleed that won't stop. Before you stop that bleeding, check their blood pressure. If they got a blood pressure that's really high, let their nose bleed. Now get on the phone or your radio and talk to med control. But the arteries in the nose may be acting as a pop-off valve. If you stop that bleeding, guess what? The next artery that pops may be in their brain, all right? And so just let them bleed, watch their vital signs, watch their airway. But again, if you got a really high blood pressure, I would not stop that without talking to the ER to find out exactly what they want to do. Anticoagulant use, and this is a large number of people, and this would depend upon the anticoagulant that they are using. If they're on aspirin, they'll be fine. They'll use TPA. If they're on Plavix or some other type of really, really strong anticoagulant, that may eliminate them as well, just simply because now you're taking the blood where the platelets are already not sticking together, and you're making it even worse. And the last one here is hypoglycemia. Why? Because they're going to be really concerned about increasing free glucose in the vessel for it to spill out into the brain. Now, hypoglycemia is not an absolute contraindication. It's a relative contraindication, all right? If your patient shows up as having an ischemic stroke, and they're going to send them into CT, if the vessel integrity is still there, chances are like 90% or higher, they're going to give the patient TPA, okay? And then they'll address the glucose slowly, probably starting out with an IV infusion of diluted D10W to raise the blood glucose up slowly and under control. So again, like I said, one of the things that you need to do is you need to teach others about stroke. One of the best things that I ever saw was that there was an EMS agency that decided what they were going to do is they were going to go and start teaching the beauticians, the people that do hair in the community, is in a small town, but in this community about signs and symptoms of stroke. Why? Because you have people that are coming in all the time, getting their hair done, and in particular, older females. This is a small southern town, and that way they can say, hey, let me tell you what I learned. And now the beauticians are educating the people that are coming in to begin to watch for these signs and symptoms of stroke so that they can notify 911. Strokes are the third leading cause of death in people over the age of 45, okay? And the other thing with strokes is that they're a frequent cause of disability, in particular for those patients that have either, number one, waited too long, or number two, that have had a stroke that is so severe and they have these contraindications that would keep them from getting TPA administered. When we're looking at these patients and taking care of them, and we're much, much better about it now than we were 20 years ago when this started, it was a battle to get EMS to begin to really take it serious because of, like I said, the conversation I had with my paramedic partner of, well, there's really not anything that we can do about these patients once they've had the stroke. But now there is a ton that we can do, and you play an integral part in identifying when those are. So the things that we're looking for here are 4 rapids. Number one, rapid recognition and basically reaction to stroke signs and symptoms, okay? That can either come from you and I as EMS, or it can come from the public. That means we're going to have rapid notification and dispatch of EMS. When you're teaching, make sure that you're telling your patients, bless you, don't load your patient up, don't load your loved one up and drive them to the hospital, because if the worst case scenario happens and your patient starts having an airway problem or they go into cardiac arrest, it's much easier to find a stationary house than it is a mobile vehicle. And so have them call 911 and to get everything out of the way and wait for 911 to get there. The other thing, the third rapid is going to be your rapid transport and notification to the hospital. You need to notify the hospital just as soon as you know, because what's going to happen is that they are going to clear out, if they have multiple CT machines, if you're going to a large hospital, they'll clear out one. Most of your smaller hospitals, which can be a stroke center, okay, will clear out their one CT machine that they've got going on and await your arrival. But it takes a little bit of time for that to happen. Once they get into the hospital, the physician will meet you, do a quick assessment, and then the patient goes straight back to CT where the CT is done, and then they can make a decision on the treatment of our patient. The goals here set off by the American Heart Association is that once you get to the hospital, that your patient is going to be assessed by a doctor within 10 minutes. Most of the time, this is supposed to happen at the door as you're coming in. Landon, with Estill County, do you see this happening at the hospital over there, or do you move your patient, you move them over to the bed and then they take them back? Okay. What's that? So do you go, you transport, bypass them for a stroke and go into Lexington? Is that what you, okay. Or do you come here? You go to Lexington. Well, see, that actually makes sense. I mean, the hospital in Estill County, it's a good hospital, but it's a critical access hospital. It's really small, okay? And so they're not able to handle a lot of major things. So what you're saying as far as going straight in, don't laugh at me. I'm trying to be politically correct here. It's a good thing for your patient. But again, well, what happens when you get to Lexington? Do you still have to move your patient over? Okay.
They can one up there and they met us at the door about this whole place.
Okay.
They did like an entire team of like 15 people.
Yeah, Baptist is the stroke center for Lexington and Central Kentucky. UK is expert in trauma and transplant. Baptist is more cardiac and stroke. And so, and like I said, they're both really good hospitals, but that's their specialty. And that's the way that it's supposed to be done. Once they go back, they send them back to CT, and they should get the CT and the interpretation of the CT done within 25 minutes, again, of the time that you hit the door, okay? And then the interpretation comes back, and then basically what happens is we're looking for the medication to be delivered within 90 minutes. Now, in most situations, that happens a whole lot quicker than that, okay? Occasionally there are some delays. There can be some technology problems with CT. And again, with smaller hospitals, what happens, and again, one of the reasons why if you're working with a smaller hospital, so for example, I consider London, Laurel County, the hospital in London, quote, a smaller hospital, even though the building is really quite large. What they may have to do is I don't know if they've got 24-hour radiology coverage. I suspect they probably do, but they may have to call in a CT technician to get ready. So that's another reason why it's important for you to notify where you're taking your patient as soon as you can. In those small hospitals, they're not going to have a radiologist on staff. So what they'll do is literally the magic of internet is they'll send them somewhere. I know when we started our stroke center, we were a level 2 trauma center at the hospital that I worked at in Dalton, Georgia. But we did not have 24-hour radiology coverage. So what we would do is that we would send the CT to a radiologist in Australia. Reason being is that their day is our night and our night is their day. And so I always had a radiologist there that was able to take a look at that and give an interpretation really, really quickly. And so the big thing that we're looking here is door to being admitted into the hospital, not door to needle, but door to admission time of 3 hours or less. Now, those of you that take patients into ERs, you know that Nothing happens in an ER in 3 hours, okay? But this does. This does. And so it really does work very, very well. Again, strokes can be categorized into two different divisions. One caused by block, ischemic, one caused by a rupture of the vessel, almost always an artery, or hemorrhagic. When we're looking at this, the blockage in an ischemic stroke can be either caused by a thrombus or an embolus. What's the difference between the two of them? What is a thrombus? There's a thrombus among us.
Isn't a thrombus where a clot is like just staying still and it doesn't travel anywhere? And then when it potentially does, it travels anywhere.
So-
It breaks off.
So, yeah, you're exactly right. So the big thing here is a thrombus is a clot, and embolus is anything else. It could be fat from a fracture. This is one of the reasons why they get patients up after they break their hip, because obviously they don't want to develop pneumonia, but also the longer they sit there, the greater the possibility of a fatty emboli goes in through. It could be air that comes through. In your OB patients, it is possible that it could come from amniotic fluid during the delivery process. So basically, a thrombus is anything that's related to a blood clot, and emboli is everything else. So just kind of keep it that way. The bottom line here is just like we talked about it in our lecture on a patient having an MI, is that the brain begins to die off as a result of hypoxia. Just like the heart, the brain does not regenerate tissue. Once it scars off, it is gone forever. The really good news is that in ischemic strokes, if we have early recognition and we have rapid transport to the right facility, the negative effects of an ischemic stroke can be reversed in almost 90% of cases. That's huge. That, to me, that puts it into the miracle category of just a couple of decades ago, these patients were relegated to going through learning to talk, learning to eat, learning to walk again, to now they go home with no symptoms whatsoever 24 hours later. And so that's one of the pretty cool things about medicine. Again, when we're looking at any type of infarction, what's the precipitating cause of an infarction? Now remember, an infarction is death of tissue. From a cardiac perspective or from a cerebral perspective, what's the precipitating cause? That's the back end. That's the back end result. But what actually leads to it?
Not enough fear.
What leads to that? What did you say?
Something obstructing the blood flow.
What leads to that? You're all giving me front end things, but you're not giving me the most front end thing. True for heart or for the brain. What? Also known as? Say it again. Inflammation. Okay. Inflammation is the precipitating cause of both strokes and heart attacks. All right. And so what we want to do is that we want to reduce the inflammatory process in the brain. Again, if we give oxygen to a patient that does not need it, what does that do to our patient? It causes inflammation by releasing what? Free radicals. And remember, free radicals is the same thing, Taki, as that little man on the inside with sandpaper, and he's roughening up the inside of that nice smooth artery. And now that nice smooth artery has ridges in it, and we can make the clot worse. All right? In the cerebral circulation, do we have a concern about nitrogen washout? And regardless of what you tell me, yes or no, be ready to defend your answer. Yeah, I'm looking at you. No, I'm looking beyond you. I'm looking at Sydney. What do you think, Sydney? Yes or no? Why? Yeah, because is not an answer. You can't do that until you're a parent. Because I said so.
Because you told us so.
Hey,
Nice try.
that's great.
Does nitrogen washout come into play with cerebral circulation? Yes or no? Why? Yes, the answer is yes. Why?
Because it affects all the vessels the same.
Nitrogen washout has an impact on all of the arterial system. Now, again, somebody teach me, what is nitrogen washout? And what happens? Because the vessels what? To not be able to dilate. So we wind up with constricted blood vessels. So again, in your patients that's having a stroke, here's your criteria for oxygen. Number one, SpO less than 94%. Number two, they look like they're having trouble breathing. Or number three, or a combination of any of the above, they look at you and say, I feel like I'm having trouble breathing, or I feel short of breath. Then we give them oxygen. We start with the lowest amount that's appropriate for the situation, and we ramp them up. If we got a patient that's in severe respiratory distress, don't start them on 2 liters of oxygen via nasal cannula. No, no. Give them a non-rebreather, okay? But you want to start them on the lowest amount that is appropriate, okay? Again, what we want to do, and in particular, is that we don't want the edema from inflammation to continue to cause our brain to swell. Remember, it can come, and like we were talking about in the review with trauma today, there's only one place for it to go, and that's through the foramen magnum. And when that happens, our patient has no life. Either literally they will die, or figuratively they will remain in a persistent vegetative state for that. Now, we can have hemorrhagic strokes that occur down deep in the brain, or we can have hemorrhagic strokes that occur on the surface of the brain. End result, same thing. We're increasing the pressure in the brain, okay? And so those are still going to be very, very dangerous for our patient. We can also have causes of hemorrhagic stroke that are congenital. Basically, what happens is that at a junction, in some patients, that vessel is weakened rather than strengthened, and that's where the blowout occurs. Bella.
What are the differences between a stroke and an aneurysm?
Hold on to that. I'm going to get to that, I promise. Now, when we're looking at this, the big thing to kind of keep in mind is that if you have what's known as an AV malformation or an atriovenous malformation, think of it this way. There is a certain area where the arterial system transitions now over to the venous system as the blood has been delivered to the cells, and now it's got to be returned back to the heart. At that area, that's going to be known as an AV junction. It is normally very coordinated, very well structured. If you have an AV malformation, it's kind of like, under normal circumstances, it has kind of like the symmetry of like a spider web, okay? It's very, if you look on one side of a spider web, it has a tendency to look very similar as the other side, so it's very organized. In an AV formation, it's almost like someone took a crayon and did this, okay? Kind of like if I were to try to do any art. It is all over the place. And the other thing that comes along with those is going to be the fact that those areas are very, very weak, okay? Now, the other thing that happens, especially when we have bleeding inside the brain, is that as that bleeding increases, the pressure increases, and not only is it compressing the brain tissue, but it now begins to tear brain tissue apart. So brain damage can occur really, really quickly in these patients. The other thing to remember is that if you have it And typically it's going to be on one side or the other. If you have signs and symptoms of weakness or paralysis, the right side of the brain controls the left and vice versa. So that kind of gives you an idea of what part of the brain is being affected. Also, if we have a brainstem stroke, our patient may just simply go into cardiac arrest quickly after onset of symptoms, because that's where the vegetative functions are taken care of. Regardless of wherever the bleeding is, if it is a hemorrhagic stroke, we're going to now begin to see an increase in intracranial pressure, as evidenced by what that we talked about today in trauma. What else is going to occur? One of the vital signs. We could potentially see Cushing's triad. Yeah. So if it gets serious enough, most definitely we can see Cushing's triad. Prior to that, though, has to do with blood pressure. Say it again. What would we see with the blood pressure as the ICP increases? Say it again. What widens? What's that called? Say it again. Pulse pressure. So both of you, good job. So yeah, pulse pressure now begins to widen. That number progressively gets larger, okay? Here's the other thing, a little tidbit for trauma that I forgot to share with you. If you've got a patient that has a head injury and you're beginning to get a narrowed pulse pressure, look for bleeding somewhere internally, okay? Because that pulse pressure should be going up. If we don't get our patient to a hospital, and if we don't take care of our patient, the brain will herniate, all right? Now, again, what are y'all going to do for this particular patient that's having a stroke? What diagnostic tool are you going to use? Before that, end-tidal. Again, end-tidal helps us to recognize acidosis. And so by just simply watching that helps us to understand, are we beginning to get an increase of pressure? Okay, sir?
Completely like off topic, but not off topic, but if you have a patient that's got a blood pressure of say like 260 over 150, they're not presenting with stroke symptoms, like a chest pain, are you still giving nitro and everything?
Okay. So you just say they are or they are not having stroke symptoms? Oh, yeah, in that situation, if they're having chest pain and I feel relatively certain it's coming from cardiac, then yeah, most definitely. Again, because remember, we're going to go with what's going to kill our patient first, especially if we identify a STEMI on a 12 lead. So yeah, I would in that situation. Good scenario. So again, the three areas that are most often affected are motor, speech, and sensory. Okay, this is what leads your patient to not being able to move because of one side of weakness or an ability to speak or an inability to speak clearly, as well as sometimes your patients, again, will often lose sight of one side or the other when they have a stroke. It's part of sensory. Or literally, you may touch a patient on the paralyzed side, and they may not be able to feel you. Here's the thing with strokes, okay? If you have a patient that has these symptoms and they come on over a period of hours or days, it's probably not a stroke. If it's days or even longer, it's probably going to be some type of a tumor in the brain, because that's much slower. With stroke, the onset of symptoms is acute. By acute, I don't mean 30 minutes ago, I mean like 2 minutes ago. The patient was fine, and now they're sitting here slumped over with their arm hanging down, and you've got facial droop on the left side. Same way, And that's going to be true regardless of whether it's an ischemic or a hemorrhagic stroke that comes into play. Yes, Martina. Okay. I'm sorry, Brandon, could you hear? I don't want to make her talk again. Oh. So new onset of Bell's palsy. I'm glad you asked that because in my tutoring sessions, I actually have a question about how to distinguish the difference. So Bell's palsy typically will come on slowly over hours. And here's the other thing. The only time you typically are going to have a patient that might call you and they're having Bell's palsy will be with their first episode. Because any subsequent episodes, they're gonna recognize what it is. Okay? And so with Bell's palsy, generally what you're going to have is if you have facial droop on one side, you're also going to have weakness and or paralysis on that same side. That's almost always going to be a given. So that would be another idea or another trigger that would help you to differentiate the thing. Second thing we would look at is most of the time, again, with strokes, pressure is going to be up. Bell's palsy is caused by an inflammation of a nerve. It's not going to raise the blood pressure. Very, very good. Thank y'all for putting up with my hardness of hearing. The other thing is comes back, Taki. TIA. So, a TIA, also known as a little stroke, okay? A little stroke, the pure definition is going to be stroke-like symptoms that resolve within 24 hours, okay? Most of the time, those stroke-like symptoms are going to resolve in an hour or less. And so you can have a patient that will have all the classic signs and symptoms of an ischemic stroke. You generally won't have, I've never heard of a patient having a TIA with a hemorrhagic stroke, just simply because the headache is so intense and very debilitating. But if you've got a patient that has a TIA, transient ischemic attack, same symptoms, facial drooping, maybe speech slurring, weakness or paralysis on one side, and then they go away just as quick as they had an onset. That's an important thing to find because many times you will, and most of the time, gentlemen, it'll be a male that his wife will call you out or his partner, and by the time you get there, Landon, it's kind of like everything's gone, and he's saying, I feel really stupid about bothering you. You got more important things to do, and I don't want to go to the hospital. That patient has a 1 in 3 chance in the next 90 days of having a major stroke. You got to use all of your persuasive abilities to get that patient to go to the hospital. And so, you may have to turn to the patient's spouse or partner and let them know, hey, if this, he has a stroke over here, you're going to have to put diapers on him and change him. I've used that before, and usually it's pretty effective to get the partner to convince them going to go. Either they'll go with me and go to the hospital, or they'll drive into the hospital. And if that happens, follow the patient in. Stay committed into that call, but follow them in. But that's what that is. Good, very good. The thing about strokes, again, is that it can often affect the soft palate, which leads to a big problem as far as being able to maintain your airway. And in particular, what you're not able to maintain is the control of the secretions. Normally what we're able to do, we get salivary forms, we swallow it, it's no problem. With patients that have strokes or TIAs, they are not able to control the secretions on that side, and so now it can become an airway issue. Look at your patient's pupils, okay? The larger side or the pupil may be blown on the side of the brain if it's a hemorrhagic stroke, because you've got bleeding that's occurring in that area, and it's putting pressure on the optic nerve, which now leads into causing that pupil to now begin to dilate. Colin.
Jumping back to PI news real quick, if you're en route and already called a stroke alert and they convert out of the stroke symptoms, do you still leave it as a stroke alert?
Yep. Yeah. Once you have called it, you just leave it alone. And now you'll notify. What I would tell you to do is you would notify the hospital that there's been a change and the symptoms have resolved. That guy's still going to CT. Now, he may or may not get DPA, but he's definitely still going to go to CT. Good question. Good question. Hemiplegia is, oh, Ryan.
So for the flow equals, is that the only way to differentiate a hemorrhagic
Oh, no. So within, and this kind of comes back to what Bella's question was as far as an aneurysm. Basically, an aneurysm is simply any kind of blood vessel that ruptures and blows out. Okay, so we have aortic aneurysms, we can have pulmonary aneurysms, we can have aneurysms of the coronary arteries. Stroke is an ischemic stroke is an aneurysm of the artery in the brain. Here's the big thing that you're looking at with ischemic strokes, generally rapid onset of paralysis, facial droop, speech slurring. With an ischemic stroke, you may or may not have those symptoms, but what will happen is that the patient will have a sudden onset of what they will frequently use, these very words. This is the worst headache I've ever had in my entire life. Okay? Now, many times it may be, let me back up. Sometimes it may be difficult to differentiate that headache from a migraine. The big difference between an ischemic stroke headache and a migraine headache is a migraine headache is going to take an hour or longer to crescendo up to that point of where it is really hurting and you're nauseated. With an ischemic stroke headache, basically what happens is the vessel blows out, the headache begins instantly because the brain likes blood as long as it's kept within the arterial system. Once it spills out into contact with the brain tissue, it's almost like the brain tissue itself seizes up. And so that sudden onset of the worst headache with or without those other signs and symptoms that we have with an ischemic stroke would be your identifier. Is that all right? Okay. So if your patient often, again, will have with not an ischemic stroke, but a hemorrhagic stroke, their eyes will often be turned away from where the bleeding is. So if you ask your patient to follow your finger and we've got bleeding over here in the left hemisphere and you're going this direction, they do fine over this way. But when you come back over here, then when you get over here to a certain point and they're trying to look, you'll see their eyes quickly dart over here off to the right. Your patient may be cool, clammy. They could be potentially showing signs and symptoms of shock because the sympathetic nervous system has kicked into overdrive because the patient knows something's occurring, but they're not able to control it. The patient may experience aphasia. Aphasia is speech disturbances. That's the medical term for it. Their speech may be slurred. They may say inappropriate words. They may get their words jumbled up. So I think, Sydney, you told me you saw some of this in the patient that you transported out. And so that's going to be a big indicator that this is going to be our patient that's going to be having a stroke. There are two primary types of stroke screening tools that are utilized. They're both named for cities. One is called the Los Angeles Pre-Hospital Stroke Screening, and the other is called the Cincinnati. The Cincinnati Pre-Hospital Stroke Scale is the more common of the two, all right? Why? Because if you look here, we have a lot of different things that we're having to assess. Within the LA stroke scale, we're looking at blood glucose, we're looking at facial droop, grip strength, arm drift, as well as with speech and the different degrees of those. One of the nice things with the Cincinnati is that we're simply looking at the face. Does it droop or not? Arm, do we have one side weakness or paralysis or not? And then speech. Do we have trouble with speech or not? Anytime that we have one of these findings that we find as abnormal, that's a 72% indicator that our patient's having a stroke. So it is pretty sensitive to identifying that your patient is having a stroke. If you're assessing facial numbness or weakness, one of the things that you're going to want to do, because some patients, when you're looking at them, they may look kind of like I'm looking at you right now. They're there, but you don't see any facial droop whatsoever. In assessing the facial droop, what you want to ask your patient to do is to smile as big and as exaggerated as they possibly can. And that might reveal that there is facial droop when just looking at them from kind of a flat affect, you don't see anything. Okay, so always when you're assessing that, tell them to smile as just as big as they possibly can. Again, this slide kind of goes into what's happening with our TIA. Basically, we've got a reduction in blood flow that causes a problem with symptoms that come up. Now, it could potentially mean that we've got a clot, a thrombus that is moving, or an embolus even that is moving. So it comes into one area, it blocks it off for a short period of time, and then for whatever reason, because generally what's going to happen is our pressure is going to go up, now it gets dislodged and moves on. The symptoms resolve, but the problem has not been reduced. And again, that's why these patients need to go to the hospital. Once the TIA resolves, they will have no residual negative effects. They'll have the same range of motion, the same ability of speech, and everything else that they had prior to that. Ryan.
Does a patient who has a TIA, do they also have an increased risk of the following?
I can't say conclusively that they would, but I would assume so, because typically if you've got a clot one place in the body, you probably got it someplace else. So I would say yes, I think that they would, but again, at this point, that's just Bill's opinion. But I think that they might. Taki. No, we do not want to give our stroke patients aspirin because they won't get the clot busting drug until they go to CT. And the reason they're going to CT is they're looking to see, is there any blood in the brain? It can be even just really, really small amounts. If there's any blood, any bleeding in the brain whatsoever, they're not getting TPA. So we don't want to give them aspirin. Theoretically, yeah, it could possibly help the patient, but the risk is too great that we could turn an ischemic stroke into a hemorrhagic stroke and it wouldn't do anything. Okay, go ahead. True, but what you've got to do is you've got to think about the acuity of if you are wrong. So so this is one of the things about medicine is that you do a risk-benefit analysis. Truly, it may help 9 people, but if it's deadly, always for the 10th person, they're probably not going to advocate that as a type of treatment. And so again, think about it this way. 87% of the patients with ischemic strokes recover after they're given TPA. But they're not given TPA until they go in with the CT and they take a look inside the brain to make sure that there's no bleeding there whatsoever. So that would be the rationale why we would not administer aspirin to these particular patients. Again, just kind of remember a TIA is a high risk event. get your patient to go to the hospital. It's important. The most common artery that's involved in a patient having a TIA, one or both of the carotid arteries. If you got a patient that's having a TIA, what assessment should you do on them? Sydney, say it again. Now you do your stroke assessment. Let's say everything has resolved. What else should you do? Let's say the blood pressure is okay. Let's say it's the perfect blood pressure, 120 over 80. Say it again. Not peripheral pulses, and we're going to compare something. Muna, what? Not Strider. Oh, what are we going to do with the carotid? Compare what? Now think about this. If most of the clots that cause TIAs are in the carotid artery, do we want to come up here and start checking the carotid pulses? No, but what we can do, we take our stethoscope and we can listen for what? Starts with a, what is it called? You're right. What's it called? Starts with a B and it ends with, second letter is Breeze. 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 You got it after I told you. That's pretty good.
I know.
Okay. Try to get it before I tell you the next time. So you're going to listen for a breeze, all right? You're not going to want to put a lot of pressure there, but remember, with your stethoscope, you don't want to put a lot of pressure anyway. So listen for a breeze sound that would be there, okay? All right. B-R-U-I-T-S. It's not spelled in any way, shape, or form the way it sounds. Welcome to English.
No, you were joking.
What's that?
I thought you were joking.
No, it's B-R-U-I-T-S. Breeze. So it's not like the football player, Drew Brees, although it's pronounced the same, all right? When we're looking at these patients, again, there's the key thing that you're going to do for your early stroke or your TIA patient. When you've got a patient that's got a high blood pressure and they're having a stroke, do not lower the blood pressure, okay? Why? It's one thing, if we lower it, we're going to reduce perfusion of the brain. What's the other? Say it again, David. What kind of stuff?
Bleeding blood, if it's a hemorrhagic stroke, or you just like progress the clot further.
You're going to progress the clot further, because think about it now. If this is our artery and the artery is occluded, and now, Landon, we suddenly do this, what's liable to happen? Yeah, the artery is going to move. It's going to become mobile, okay, and it's going to go to another part. So don't lower the blood pressure. They'll do that at the hospital. Watch your patient's airway. Remember, soft palate, bottom part of the mouth, as well as the neck runs into problems with airway. So we want to watch that really, really closely. Have your suction equipment available. If the patient is able to sit upright, let them sit upright. If for some reason you're concerned, then put them into a lateral recumbent position. Question: if you got a patient that has paralysis, you're going to put them on the paralyzed side or on the non-paralyzed side. Why?
Exactly.
She just called me dumb.
Because
Let the record show that Bella just called me dumb. Yeah, you're right. And so it's just simply not, so we put them on that side. You're right. Watch the patient's airway closely, all right? If the patient stops breathing, or if their respiratory rate or tidal volume is insufficient, we can begin to ventilate. Start down on the low end. Let your your pulse ox and your end tidal guide your rate and tidal volume, just like we talked about for head injuries. Taki.
So on the paralysis side, like the vessels in the same side will be constricted, right?
In what kind of stroke?
So if they have lost their eyesight.
If they've lost their eyesight, it's most often going to happen as a result of a hemorrhagic stroke, of where the bleeding is beginning to put pressure on the optic nerve.
Okay, so the vessels in the right side will be constricted.
Potentially, it depends upon how much blood, how much bleeding has occurred, as to whether we're not beginning to get herniation or shifting of the brain. If we've got a large area that's bleeding as a result of coming from a large artery, or the potential that the patient has been on a really, really potent anticoagulant, then yeah, we would begin to see some constriction as evidenced by an increasing in the blood pressure. If it's early on and it's a slow bleed, then the constriction may not even be happening yet. Okay.
So it's only a monitor, maybe it's not the vessels.
Monitor the blood pressure, because there's really nothing that we're going to be able to do about the vessels. Because again, even if the pressure is up because of constriction or compression, we're not really going to do anything to try to bring that pressure down. To do so may be fatal for our patient. Avoid hyperventilation in your patient for the same reason that we talk about as far as hyperventilation in your head trauma patient. The same mechanism is at play. And again, use end tidal as well as SpO2. When we're looking at assessing our patient, okay, check their blood sugar. All stroke patients get a blood sugar check. Period. End of story. Okay? All of them get a check. Because because the low blood sugar can often mimic signs and symptoms of a stroke. Remember, one of the things that can cause or can be evidence of a stroke is slurred speech. So can alcohol, so can drugs, so can a low blood sugar. So we may not be able to do a lot for drugs, with the exception of a narcotic. We may not be able to do anything much about a stroke other than supportive and correct transport. But there's definitely something we can do for a patient with a low blood sugar, okay? The other thing we want to be careful about, though, is if our patient is having a stroke, is two things. Number one, we've already talked about if we introduce high concentration of glucose into the brain, now basically we eat the brain away, okay? The other thing that happens is because dextrose is so concentrated, even at 10%, it now raises the intracranial pressure in the brain by fluid shifts, okay? So one of the things that we want to look at here is that we only want to give dextrose or glucose if our blood sugar is less than 60 and we feel like that the blood sugar is beginning to drop. The other thing I would tell you is start out with D10 and give it really, really slow, much slower than what you would for a non-stroke patient. That way you can watch and see, is the patient beginning to get better? And if they are, don't worry about giving the whole dose of the D10, all right? So watch that really, really closely. I strongly encourage you to go through and to review that section in your book as well as within your pocket guide on stroke and diabetics. Watch your patient's extremities. Again, remember, they may have absolutely no control over their arms and legs. So pad them and strap them in. We don't want to cut off circulation, but we also don't want to damage them as we're going out through doors. This should be for all your patients, but in particular for your geriatric patients that are really, really old, that are now beginning to have really, really thin skin. because what happens is the skin begins to tear. That's a great method for your patient to get an infection that could lead into sepsis. Always remember, talk to your patient in a stroke. Simply because they can't talk back to you does not mean that their hearing has been affected. One of the things to keep in mind is that as we go unconscious, whether or not it's for a surgical reason or if we're in the dying process, hearing is one of the last senses that we lose. If you're making jokes and making fun of your patient or talking about what's for supper, that patient may remember that, and that's not going to be the best thing for your patient, first of all. And second of all, they may potentially come back with a legitimate complaint on you if they survive. Last thing I want to put on here, guys, let your ER know as soon as you can so that they can get everything started and underway. Good discussion today, all right? Any questions about this or anything else?